Welcome to the video demonstration of gastric aspiration technique in infants. The Sentinel TB project on pediatric drug resistant tuberculosis had developed an 18-minute video on gastric aspirate technique in children on 14 March 2014 as part of a webinar. So, we have adapted that video for this course and we thank them for permitting us to adapt the video. Our special thanks are to Dr. Elizabeth and Dr. Carlos for their contribution in the performance of the gastric aspiration procedure and for the development of the video. We all know that the accuracy of microbiological studies is affected by the quality of sputum samples submitted, and the deficiencies in quality and or quantity can compromise the result. Given the paucibacillary nature of TB disease in young children, appropriate specimen collection is very important to improve the bacteriological yield of the sample. However, collecting respiratory specimens in infants and in young children, especially less than 7 years of age, can be very challenging because they are usually unable to be effectively expectorate. So, what is the principle behind this gastric aspiration technique? While the child is awake or at sleep, the mucociliary system moves the mucus to the upper airway, where it is then swallowed and moved down the esophagus to the stomach, where it remains until gastric emptying occurs. This aspiration of gastric contents is designed to optimize the bacteriological yield of a gastric aspirate. So, the nasogastric tube is passed through the nose. This is then passed through the esophagus into the stomach to collect the gastric contents. Gastric aspiration is often not successful because the nasogastric tube does not come in contact with the mucus. This can be because the nasogastric tube is not advanced far enough to reach the mucus. In that case, advancing the nasogastric tube can allow the mucus to be aspirated, or the nasogastric tube may be in a different section of the stomach than the mucus. In that case, turning the child 90 degrees into the lateral decubitus position may also help the nasogastric tube to reach the mucus. If possible, the nasogastric tube should be placed the evening before the gastric aspiration. Then in the morning, the gastric aspirate can be collected expeditiously before the child awakens. The timing of the procedure. The nasogastric aspiration should be done in the early morning before peristalsis empties the stomach. The child should be kept flat as much as possible to prevent stomach emptying. All care should be taken to prevent the child from waking up and sitting up early and therefore starting peristalsis. The child should not eat, drink or take any medicine for 3 to 4 hours before the procedure. There are few contraindications to nasogastric aspiration. The nasal passageway obstruction, for example due to choanal atresia or esophageal atresia, recurrent prolonged epistaxis or nosebleeds, possibly due to a bleeding disorder, the stomach not being empty, that is less than 3 hours of fasting, due to risk of aspiration if regurgitation or vomiting occurs, and in case of respiratory distress. The risks and complications of nasogastric aspiration. The risks and complications include discomfort and pain, epistaxis due to tissue trauma to nasal mucosa or tissue trauma to tonsils or adenoids. The measures to prevent and minimize these risks involve installation of a vasoconstrictor, for example oxymetazoline nose drops in each nostril, generous application of lubricant gel to nasogastric tip and or nostril, selection of an appropriately sized tube with smoothly rounded tip, and then by using the technique in a gentle manner. Other risks and complications include gagging, nausea or heaves, vomiting and aspiration. If already known to be at risk for these, pre-medication with antiemetics should be considered and suction should be available at bedside in case of vomiting. Further risks and complications include respiratory tree intubation or vocal cord trauma. This can be minimized by astute listening for muffle or hoarse cry and by gentle technique. Esophageal perforation can be minimized by a gentle technique of this gastric aspiration procedure. Anxiety and inconsolable crying can be minimized by reassurance and comforting the child. Indications for stopping the procedure. If the child reports intense discomfort preventing the passage of the tube, if the child develops increasing respiratory distress and or sustained increase in respiratory rate during the passage of the tube, if the child develops cyanosis during the passage of the tube, or if parents do not want to continue with the procedure despite explanation and reassurance. The equipment and materials required for the gastric aspiration technique involves nasogastric tube usually in the size of 6, 8 or 10 FR, oxymetazoline nasal drops to reduce the chance of epistaxis, lignocaine 2% gel to reduce discomfort and it also helps in lubrication, waterproof marker pen, emesis basin in case of vomiting or regurgitation, 2 to 3 falcon tubes of size 50 ml, sterile specimen container, example is a sterile urine collection cup. Sterile gloves for person performing the procedure. The gauze for gloves to immobilize the infant's hands if placing the nasogastric tube the day before. Paper adhesive tape to secure the nasogastric tube if placing the tube the day before. Scissors to remove the tape from the nasogastric tube if placed and secured with tape the day before. Disposable gloves, flashlight, stethoscope, 20 ml syringe. Resuscitation equipment should be available include bag mask, laryngoscope, endotracheal tube, introducer, subcutaneous terbutaline, oxygen and suction equipment. Personal protective equipment. They include protective gown, N95 mask, protective eyewear and sterile field. Materials to process the specimen include sterile dropper single use which is disposable, sodium bicarbonate, pH indicator strips preferably in 0.5 increments, cooler for storage if transport to lab is not immediate. Elements of a good nasogastric tube. Use the largest nasogastric tube possible. Infants generally use a size 6 FR, but older children should use an 8 or 10 FR because the 6 FR collapses easily and can be blocked by thick mucus. The nasogastric tube should be firm and non-collapsible. There should be 4 holes at the tip of the nasogastric tube. This will make the tube less likely to become blocked. The nasogastric tube should be coated to reduce friction. There should be a cap to prevent gastric fluid leaks, especially if the tube is placed the day before. The nasogastric tube should have measurements marked on the side. The tube should be long enough to allow you to work comfortably. Sterile technique is very important to prevent contamination of the specimen. Hand washing should be performed before and after patient contact. Hands should also be washed after coming into contact with any item that was used on the patient. Universal precautions must be used. Tuberculosis and other illnesses can spread if the child coughs or just through close contact with the child. All people involved in the procedure should wear a protective gown. Everyone in the room should wear a well-fitting N95 respirator. If the respirator is deformed, becomes wet with sweat or soiled with blood or other biological fluid, it should be discarded. Protective eyewear should be worn by anyone performing the procedure that is not wearing eyeglasses. Sterile gloves should also be worn by the person performing the procedure. The wrapping of the sterile gloves can be used as the sterile field during the gastric aspiration. Securing the child for the nasogastric tube placement and aspiration. If available, a papoose board is ideal to secure the child. However, if this is not available, any board can be used. Many places have a UNICEF height measuring board. In that case, you will also need velcro straps and a large sheet to firmly wrap the child in. Make sure the procedure is always done in a separate well ventilated procedure room to decrease the risk of transmission to other people. It is important to wrap the child securely. Not only does this keep the child from flailing and pulling out the nasogastric tube, it also assures that when you turn the child, you are turning the whole child including the child's thorax. You will not just turn the head. That way you will be sure to be moving the stomach in order to bring the nasogastric tube into contact with more mucus. Make sure the velcro is securely fastened. Performing the procedure. The personnel. The procedure must be performed by a qualified professional with the help of 1 to 2 assistants. The person performing the procedure must know how to handle any adverse events. One person must be at the head of the bed to hold the child's head still and watch for any vomiting or aspiration. A third person should manage and distribute the necessary materials. Placing the nasogastric tube. Examine the nasal passages, preferably with a flashlight. Select the most patent nostril for insertion of the nasogastric tube. Insert 2 drops of oxymetazoline into each nostril. If using a reusable bottle, be careful to not let it touch the nose. Measure the approximate insertion length for the nasogastric tube. Measure from nostril along zygomatic process around the pinna and down to the stomach. Mark that length with a waterproof pen. Use a sterile field to decrease contamination of the specimen. Lubricate the nasogastric tube with lignocaine gel. Manipulation of the nasogastric tube distal to the nostril should be done using aseptic technique with sterile gloves to decrease contamination of the specimen. Insert the nasogastric tube through the larger nasal passage. Gently extend the patient's head back, avoiding hyperextension to facilitate entry of the nasogastric tube. When the nasogastric tube is through the nasal passage, flex the neck slightly. To verify the nasogastric tube is in the stomach, listen over the stomach as air is injected. A loud gurgle will be audible. The child's voice or cry should be normal and strong. Nasogastric tube will not advance further due to the following reasons. If the nasogastric tube is curled into the oral cavity, if the tube has passed into the upper airway or larynx through the vocal cords, if this happens, which may be suspected if the child has difficulty in breathing or has a muffled voice, the nasogastric tube must be removed immediately. The nasogastric tube has already reached the stomach and will not move further even though the mark is still distal to the nose as a result of excessively long measurement. With the nasogastric tube at the position marked by the pen, which is a neutral position, aspirate with a syringe. Make sure that gastric fluid is obtained to ensure correct placement in the stomach and not in the lungs. A 20 ml syringe is best as large syringes may cause the nasogastric tube to collapse. Advance the nasogastric tube 2 to 4 cm beyond the marked neutral position. Continue to gently aspirate. Withdraw the nasogastric tube 2 to 4 cm beyond the marked neutral position. Continue to gently aspirate. Place the gastric aspirate into the falcon tube. Replace the cover of the falcon tube after each sample is added. If the sample contains undigested food, discard it. Reposition the child into the right lateral decubitus position. Keep the head aligned with the body. As before, advance the nasogastric tube 2 to 4 cm beyond the neutral position. And withdraw the nasogastric tube 2 to 4 cm beyond the neutral position. Continue to gently aspirate the entire time. Turn the child to the left lateral decubitus position and keep the head aligned with the body. Repeat the same steps as before with advancing and withdrawing the nasogastric tube 2 to 4 cm beyond the neutral position. Continue to aspirate. If more than 40 ml of gastric aspirate is obtained, collect the additional amount in a separate sterile container. If not much gastric aspirate has been obtained, repeat the process again with the child in the supine position, which may yield additional aspirate. If the child were to vomit while in the supine position, immediately turn the child to the left or right lateral decubitus position. When finished, gently withdraw the nasogastric tube while continuing to apply suction. A green tinge to the mucus like this one indicates a good gastric aspirate. Processing the gastric aspirate sample. Measure and record the baseline pH. If the pH is between 6 and 7, do not add alkali. If the pH is less than 6, perform neutralization. Add alkalizing agent, that is sodium bicarbonate, with a sterile dropper. Remeasure the pH and titrate for a pH of 6 to 7. Refrigerate the specimen to prevent bacterial overgrowth. Transport to lab for processing as soon as possible, that is within 30 minutes. With this, we come to the end of the session of the video demonstration of gastric aspiration technique. Special thanks to all the partners and the Sentinel TB project. The key messages include: placing a nasogastric tube is not too difficult. However, collecting samples with good mycobacterial yield requires a good technique. The quality and size of the nasogastric tube can impact the quality and volume of the gastric aspirate. Evening placement of nasogastric tube followed by early morning gastric aspiration tends to offer the best sampling. Connecting the nasogastric tube with a pool of gastric juice by manipulating the nasogastric tube and repositioning the child is the key to this procedure. An immobilization board minimizes trauma and optimizes position changes, that is to connect the pool to the nasogastric tube and to protect the airway in the event of vomiting. Immediately, pH neutralization and cool storage preserves the sample while lab testing can be carried out. Thank you.